Thank you very much and welcome back. Thank you very much to the organizers of the meeting for inviting me to Bordeaux and this nice meeting. And we're going to switch a little bit topics and talk about Parkinson's disease. You will have two presentations this afternoon about another frequent neurological disorder. So as for dementia, the number of patients is increasing and was between over 30 years, the number of PD patients has multiplied by 3 and it's continued to increase. And as there are no major changes in incidence rates worldwide and in most places, this is mostly due to aging populations. But another factor that is less often mentioned is the fact that PD patients are also living longer with the disease. So not only there will be more patients in the future, but patients will also have longer disease duration and will be more complicated to treat because they will have complications. And so this really is going to introduce some pressure on the healthcare system. So we really need ways to try to prevent or at least delay the onset of Parkinson's disease, and this was mentioned this morning. So there's a genetic contribution to Parkinson's disease. There's a number of Mendelian genes, but these account for a small proportion of the patients, and the heritability of Parkinson's disease is rather low, except for very young patients, so patients who have a young onset of the disease, because the genes that are causing Parkinson's disease are usually associated with younger onset of the disease. There's one interesting finding I think that's relevant for what we're discussing here is that the two most frequent genes, LRRK2 and GBA, have a reduced penetrance, which means that there may be other factors, maybe genetic, but maybe also environmental, that modify the penetrance of the disease. And so this is a nice model of gene-environment interactions. But so in addition to genetic factors, there's a number of environmental factors that have already been identified in Parkinson's disease. Some of them increase the risk and some of them decrease the risk, and we will discuss some of these later. But before, I would like to discuss two methodological issues that I think are relevant for Parkinson's disease, but also for dementia and other neurodegenerative diseases. So the diagnosis of Parkinson's disease is mainly clinical. There's no real test that can be used in the clinical setting, at least until now. And despite the use of well-defined criteria, there's a risk of misdiagnosis. And in autopsy studies where there were patients with PD that were autopsied, the accuracy of the disease is about 80%. So you see that there's, even in very experienced centers, there's a risk of misdiagnosis with other causes of Parkinsonism, such as atypical Parkinsonism. And so that's in clinical settings, but in epidemiological studies that use healthcare databases, there are some studies that have tried to validate the way the patients are identified, and these are those two studies in the US. And you can see that compared to expert review of medical records, using ICD codes alone to identify PD patients is associated with a risk of misdiagnosis. And you can see, for example, that in the Mayo Clinic or in the VA databases, the positive predictive value of this algorithm was only 46%. So there's a risk of misdiagnosis. And we've done some analysis in the UK Biobank. We started working on the UK Biobank, and we found out that, in fact, the way they identify PD in the UK Biobank is based on hospital records and death certificates. And this is a problem because PD patients are not often hospitalized during the first years of the disease. They're mostly hospitalized when they have complications, they fall or become demented, have hallucinations. And so it means that in the UK Biobank, we identified in PD patients rather late in the disease, and also not all patients are hospitalized. So we defined, and so this is because they have primary care data including drug claims, but only for a proportion of the patients, in the participants in the UK Biobank. So only 25% of the participants have primary care data, and only for a limited period of time. So they could not use these primary care data for the whole cohort. And so what we did is for this proportion of the cohort, we used an algorithm that we've used in other studies to define PD. And then we looked at how many patients with this identified through this algorithm were identified through the UK Biobank algorithm, and we found out that, for example, that what you can see, only 78% of the patients were identified after 15 years of follow-up. But there was what I think is more important is that there's a delay between the diagnosis using drug claims and the hospitalization records, and you can see that 50% of the participants were diagnosed using hospital records after 4 years compared to the drug claims. And on the right, you can see that, in fact, using these different algorithms can induce difference in association. So here we just looked at two common, one risk factor of Parkinson's disease, sex, and one prodromal symptom, gait speed. And you can see that the association changes depending on which algorithm you use. These are, of course, very strong associations, but it's probably more problematic for weaker associations. And you can see also that we looked at the mortality in PD patients identified in these two different ways. And you see that there's a very striking difference in the ones that are identified through hospitalizations, because they had a 9-fold increased risk of death, which is a lot higher than expected for Parkinson's disease compared to 2. So it means that we're identifying patients with more severe Parkinson's disease, and that was our hypothesis. So I'm just showing this because I think it's important when we do epidemiological studies on Parkinson's disease to really look at how the patients were identified, because this has very important consequences in terms of the validity of the findings. The second issue that I wanted to discuss is reverse causation, because this is really also a major issue in Parkinson's disease, and it's really something we're starting to understand better, because the natural history of the disease, we really have made a lot of progress in the past year. So we knew before, so Parkinson's disease is due to the degeneration of a small part of the brain that leads to some motor signs, and we knew from a long time that, in fact, the symptoms appear when about 50% of the dopaminergic neurons have disappeared. And so we see that, in fact, the loss of the dopaminergic neurons starts about 6-7 years before the diagnosis. And during this period, there's a higher frequency of some motor signs, such as tremor, balance problems, etc. But what is more recent is that, in fact, we see that for some patients, there's a very long prodromal phase characterized by the presence of non-motor symptoms, such as anxiety, constipation, REM sleep behavior disorder, which is a very particular kind of problem, anosmia. And these non-motor symptoms can be present 10, 15, 20 years even before the diagnosis of Parkinson's disease. So this has led to the hypothesis that there may be two forms of Parkinson's disease, and probably this is an oversimplification, but I think it's nice to frame a little bit the discussion. So there would be one brain-first subtype of Parkinson's disease that would be the more common, that starts in the amygdala or the olfactory bulb, and I think this is also important for the studies, exposomic studies, because it can have implications in terms of the route of exposure, how the neurotoxins can enter the brain. And these patients have a more benign disease course than the body-first subtype of Parkinson's disease, where the alpha-synuclein pathology, alpha-synuclein is the protein that aggregates in the brain in Parkinson's disease, originates in the gut and then spreads to the brain through the vagal nerve. And again, here, this can have implications for the route of exposure, because maybe it means that the route of exposure is through the digestive system. And this is important because in Parkinson's disease, there's something that is a little bit striking, is that when you look at the associations with risk factors, there are many inverse associations, so exposures that decrease the risk of Parkinson's disease, and less risk factors, so risk factors that increase the risk of Parkinson's disease. And so the question is whether this is true. Are these really causal associations and protective factors, or is it bias due to reverse causation? So what's reverse causation? This is the situation in which the outcome precedes the disease and affects exposure. And for example, in Parkinson's disease, it's possible that constipation may have an effect on diet many years before the diagnosis. It's possible that patients with RBD use sleep drugs, for example, or antidepressant, it's possible that dysautonomia may change the way people are prescribed drugs for blood pressure. It's possible that weight loss, and we'll discuss this in a moment, also affects diet, that subtle motor signs affect the way people do physical activity, for example, or the risk of head trauma. And there are studies showing that people in the years before Parkinson's disease have more frequent medical contacts because they're starting to get sick, and also that maybe they have more sick leaves. And this is important for studies that look at occupational exposures. So this means that if it's important to use a life course approach in order to be able to look at midlife exposures, and this is something that we've already mentioned, it's interesting to use to do studies where we have repeated assessments of exposures in order to do trajectories analysis, or to adjust for subclinical disease, or do lagged analysis, so where we include a lag between the exposure and the disease onset, or to use other methods of to improve causal inference, such as, for example, some forms of instrumental variable analysis, such as Mendelian randomization, gene-environment interactions, or natural experiments. So I'm going to give just a few examples of reverse causation in Parkinson's disease. So on the left, you have the association between beta blockers and Parkinson's disease. And this is a typical example of reverse causation, because we've seen that patients in the few years before the diagnosis start having tremor, and beta blockers are used for tremor, in particular propranolol. So you see that the curves show that the frequency of prescriptions of beta blockers in let's see if I can do this. No. Well, I cannot. Here. So you can see here that this is time 0 is the time of diagnosis, and you can see that the frequency of prescription of beta blockers goes up compared to controls in the years before Parkinson's disease. And so if you look at this period, then you're going to see that there's an association between using beta blockers and the risk of Parkinson's disease. But if you don't take into account this period, so if you include a lag, then you see there's no association with the use of Parkinson's disease. So this is typical reverse causation. And for statins, we see something a little bit different. We see that the prescriptions of statins are higher in controls than in cases many years before the diagnosis, but then 5 years before the diagnosis, the rate of prescriptions start to become similar in cases and controls. And this is because patients start to see more often doctors than controls in the years before diagnosis. So probably motivating more prescriptions of statins for prevention. And so if you look at the association, taking into account this period, you won't see any association with statins and the risk of Parkinson's disease. But if you discard this period, then you see an inverse association. So an example of reverse causation. Body mass index is another example of reverse causation. There's a large literature because we know that PD patients lose weight when they become disease. So the question is whether body mass index before the disease has an effect on the risk of Parkinson's disease. And what we saw in this study is this is in the EIRENE study, nearly 100,000 women followed for 30 years. So we identified here the patient using medical records that were validated, we used to validate the diagnosis. And we had repeated measures of BMI, and you can see that, in fact, the frequency of obesity was lower in cases compared to controls even 30 years before the diagnosis, so a protective effect of BMI on the risk of Parkinson's disease. But you can see that patients start to lose weight about 10 years before the diagnosis. A similar thing happens for physical activity. There's a large literature on whether physical activity is protective for the risk of Parkinson's disease. So we used repeated assessments of physical activity in the EIRENE cohort, and we saw that the cases had lower levels of physical activity throughout the 30 years of follow-up, but that the level of activity started to decrease in cases compared to controls in the 10 years before the diagnosis. So if you look at the physical activity level here, you would overestimate the association compared to if you look at the physical activity level in midlife. And this is something we quickly discussed this morning, but it's possible that because patients start to be more sick in the years before diagnosis, maybe this could affect the way they move. And so we looked at whether the trajectories of moving were similar in cases in controls over the follow-up. And we found out that, in fact, there was a slightly different pattern of moving between PD patients and controls in the years before diagnosis. So here are the cases, here are the controls. So at the end of the follow-up, if you look at the cumulative number of times a person moved, you can see that controls tend to move more than cases over the follow-up. And this is important because we use the residential addresses to attribute the exposures in many studies. So if there's a differential way cases and controls move, this could have an impact on the associations. So it's difficult to do a talk about Parkinson's disease without discussing smoking, because as you can see on the left slide, on the left side of the slide, there's an inverse association between smoking and Parkinson's disease that is really confirmed in all studies with a dose-effect relation. And so this has triggered a lot of discussions because, of course, it's not very politically correct that smoking has a beneficial effect. And there's a number of biases that have been hypothesized to account for this. So survival bias, of course, because people who smoke tend to have a higher rate of mortality. But this is unlikely because we see this inverse association even for persons who develop very young onset Parkinson's disease, so before the rate of mortality becomes high. Genetic confounding is unlikely also because we see this in twins. So we see that in twins we confirm there's an inverse association between smoking and Parkinson's disease. It could be reverse causation, and it has been hypothesized that PD patients quit smoking more often than controls, but then it would need to happen very, very early in life because we see an inverse association between smoking even for persons who stopped smoking 30 years. And Mendelian randomization studies, in which you use a gene associated with the likelihood of smoking, confirm this inverse association between smoking and Parkinson's disease. Whereas the opposite, so whether the genetic predisposition to Parkinson's disease influence smoking, has not been confirmed. And these Mendelian randomization studies are less likely to be influenced by confounding or reverse causation. Gene-environment interactions may be another way to approach this question, and for a number of reasons, we examined the interaction between smoking and the HLA-DRB1 gene, and we found out that the inverse association was present only in persons who didn't carry a variant for this gene, and this was replicated in 2 studies. So for the potential mechanisms that explain this inverse association, this smoking by HLA interaction suggests that maybe it could be some mechanisms involving the immune response. Smoking has been shown to inhibit the alpha-synuclein aggregation. There's an effect of smoking on the microbiome, so that could be a possibility, and also an upregulation of cytochrome enzymes. About the components of smoking that could explain this association, this is really not clear at all, and there's a number of hypotheses, but really not final proof of which component of smoke could explain this association. Regarding pesticides and Parkinson's disease that have been mentioned several times until now, this is also one of the very robust associations that we see in Parkinson's disease, and the meta-analysis of occupational exposure, so people who have the strongest exposure, showed a 50% increased risk of Parkinson's disease in persons with occupational exposure. In France, we confirm a higher frequency of PD in farmers compared to the general population, and we found that farmers' men, because they are the ones who spray the pesticide, had a higher risk of Parkinson's disease, especially if they use insecticides and organochlorines. And I think that this is a nice example of implementation science that was discussed several times, is that due to these findings, PD has been recognized as an occupational disease in France among farmers, so they get a pension when they can demonstrate that they have been using pesticides for at least 10 years. Of course, the difficult part here is try to identify specific pesticides, and there are a number of studies in addition to organochlorines that have pointed to certain pesticides such as paraquat, rotenone, or dithiocarbomates. And there's toxicological evidence linking these pesticides to the mechanisms that are involved in Parkinson's disease, such as oxidative stress, aggregation of alpha-synuclein, but also DNA methylation or changes in microbiota. But of course, the number of patients attributed to occupational pesticide exposure is small, and the question is really whether residential exposure has an effect, because of course it would affect more people. And this can be done in California, where they have a pesticide reporting system that by law is able to record the exposure to pesticides, and they found out that persons who lived close to fields that have been sprayed with pesticides in a 500 buffer had an increased risk of Parkinson's disease. So that was a first study where they used that candidate pesticides, and then in subsequent studies they looked at a whole lot of pesticides, and I think this, so here for example they tested over 280 pesticides, some of which were very correlated, and they identified associations for 68 pesticides. But of course this really reminds of what Rémi Slama was talking yesterday about looking at a whole range of exposures. In France, so we don't have this pesticide reporting system, so we did an ecological study where we used data from the agricultural census that describes the regions in terms of the kind of crops they use. And we did some clustering analysis to define regions with similar kind of agriculture. And then we looked at the frequency of incidence of Parkinson's disease in these regions. And what we found is that first, the incidence of Parkinson's disease increased with the density of agricultural land, so the proportion of the land attributed to agriculture. And then we really saw a cluster that stood out compared to the other clusters. And this is a cluster where with a very high proportion of vineyards. So, and vineyards in France is really a type of agriculture that involves a lot of spraying of insecticides and fungicides. And then we're continuing to do this analysis. So we don't have information of the specific pesticides that are used for these crops, but we have crop by pesticide matrices, so that historically attribute of probability of treatment with pesticides to each crop. And we have this for four kind of crops. So we can then map the frequency of use of these pesticides to the specific regions of France. And if someone wants to use these indicators of use of pesticides in France, these are available in this website, where we have included all the indicators for many pesticides in France over many years, over 30 years. And then what we're confronted with the problem that, of course, pesticides are used in combination, and we had a lot of mixtures of pesticides. So we tried to do some mixture analysis using this method, SNMU, that is able to define mixtures of pesticides. We've identified 22 mixtures of pesticides, and then we mapped these mixtures of pesticides, and then we looked which ones were associated with the risk of Parkinson's disease, and we highlighted one specific mixture of pesticides, and then we're continuing to do this analysis to understand better which are the pesticides involved in this mixture. Now, a final, two final slides on trichloroethylene that was mentioned this morning. So there was some interest in exposure to trichloroethylene due to a case report in 2008 of a small company in which all the employees were exposed to trichloroethylene, and several of them developed Parkinson's disease or subtle Parkinsonian signs. Trichloroethylene has been shown to induce the generation of dopaminergic neurons and alpha-synuclein degradation. And then there was a small study of 99 pairs of twins in which there was occupational exposure to trichloroethylene that was assessed and associated with a higher risk of Parkinson's disease. So regarding environmental exposure, this is a toxicant that is really very ubiquitous. There's been, for example, these 2 recent studies. So one of them on the right was already presented to you this morning. And so on the left, this is an interesting study because it's sort of natural experiment where in the US there was a camp of Marines where there was the identification of very high levels of contamination of water by TCE over a long period of time between 1953 and 1987. And so the Marines that were in these bases were very highly exposed to TCE. So they identified persons who lived for at least 3 months between 1975 and 1985. And the important thing is that persons were very young where they were living in these bases. So they were on average 20 years, and they lived for about 2 years. And they ascertained PD many years later. So the exposure occurred at a really young age. And then they looked at the risk of Parkinson's disease many years later, and they found, compared to another base of Marines, so this is really what's interesting in this study, that they were able to use a very nice control group that was very similar. They found a higher frequency of Parkinson's disease in the base that was contaminated with TCE. So to summarize, so the first point I wanted to highlight is that there's many databases that are now available to do PD research, such as the UK Biobank, which is a wonderful resource. But I wanted to really highlight that the fact we need to do some validation studies on the diagnosis to understand better what's the validity of the diagnosis in these databases, and if possible to do some bias analysis. The second point is that PD has a long prodromal phase, which raises the issue of reverse causation. And it's important, for example, if reverse causation affects sick leaves, for example, for occupational exposures or the way people move. It also can affect the levels of persistent pollutants, because if they are affected by weight loss, and so we need to account for this, or do studies where pollutants are measured very early on, many years before the diagnosis occurs, and I think Roel is going to talk about that. The fact that there's this long prodromal phase also offers a nice opportunity, because now we can identify persons with prodromal PD, and there's a biomarker now, and so we could, in fact, do studies to understand which are the persons who develop PD from this prodromal PD, and it also highlights the fact that really we need to focus more on early exposures. I think PD is a nice model also for gene interaction analysis, for example, in particular for the reduced penetrance of LARC2 and GBA. And regarding pesticides, I think that there are still few studies looking at environmental exposure, so additional studies on environmental exposures are needed. And for this, we need better exposure data, similar to the ones that are in California. And I think this is more for decision makers, but we really need to obtain better harmonized pesticide data, and that would be very nice at European level to be able to do to obtain this sort of data. And the second thing I think is very important is that pesticides change a lot, and so the pesticides that we are identifying now were pesticides that were used in the past, and most of them are banned, and so we need also better neurotoxicity tests as part of the regulatory approval of pesticides, because this will be for future generations. Thank you very much.
Thank you very much for the really nice talk. I was just wondering for the pharmaceuticals if you have any data on psychotrops, like for instance antipsychotics, like neuroleptic that have direct action on the dopamine, or even methylphenidate that can have potentially protective effects. That's the first question. And I can really see the rationale behind the reverse causation with pharmaceuticals. For pollutants, except the weight loss, do you have any other explanations that could help to explain this reverse causation?
So for the second question, the fact is that many of these persistent pollutants are stored in adipose tissue. So then people lose weight, then they're going to go in the blood. And so the adipose stocks reduce. And maybe this means that if you measure the pesticide, maybe you won't find them anymore because they've already been released in the blood, and you're arriving too late, or maybe the level that you will measure will be too high. So I think it really is going to introduce some measurement error on the exposure. For the first question, so neuroleptics is really a cause of drug-induced Parkinsonism. So in the studies that we do, we always exclude persons who took neuroleptics before the diagnosis in order to be able to rule out drug-induced. There are other drugs, in fact, that could really also be involved, and we've been doing a lot of these studies on drugs, but maybe it's too... Thank you.
Just is this working? Yeah. So a comment and a question. So comment, so even though some pesticides have been banned, it doesn't mean that they're not being used for maybe other purposes, rotenone being an example of that. Still used for, say, clearing out lakes, getting rid of fish species if you're actually interested in a lake.
Or in other countries, because many of these pesticides that are banned in Europe are available in Africa, for example.
Yeah, so the risk can still be there. Actually, the question I had was, what about DBS? And if is it possible that stratifying a patient population by gene, by environment, may help to identify individuals who are more likely to respond to DBS?
So regarding the environment, I don't think there's any study that has looked at whether there's a difference in response to DBS or not. There's a lot of studies, of course, on DBS in patients with LRRK2 or GBA, and it seems to be, in particular for LRRK2, it's not a contraindication to DBS.
Really great presentation. I was struck by the reverse causality, which is always a problem in a lot of these models. But you have a REM behavior disorder for Parkinson's disease, and maybe not at scale because the diagnosis itself sometimes lags behind. But have you looked at that? So use of these drugs in individuals with RBD?
So RBD is not specific of Parkinson's disease. In fact, other diseases, for example, patients with MSA or dementia with Lewy bodies, in fact, can also have RBD before. So it's not really specific of Parkinson's disease. But I think that, yes, there's really a lot of interest at the present time to study patients with RBD and to follow them longitudinally to see what's in fact the natural history of when they're going to develop Parkinson's disease. And in fact, that even is not that clear. And it's even more important now because we have, in fact, abnormal alpha-synuclein can be measured in the blood, in the CSF or in the skin. And so there's a lot of interest really in looking at how persons with positive alpha-synuclein are going to evolve. And it's really a very active field of research.